Welcome to Oncology Morning Commute, third-line treatment of CML. Morning Commute is developed in collaboration with At Point of Care and Projects in Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. In this podcast, Dr. Gerald Radich and Dr. Michael Morrow discuss third-line treatment of chronic myeloid leukemia, and in particular BCR, ABL1 tyrosine kinase inhibitors. Who are the best candidates for these treatments? Information about the faculty and disclosures can be found at morningcommutepodcast.com/CML1. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Radich is professor in the Clinical Research Division of Fred Hutchinson Cancer Center in Seattle. Dr. Morrow is a professor of medicine and leader of the Myeloproliferative Neoplasms Program in the Leukemia Service, Department of Medicine at Memorial Sloan Kettering Cancer Center in New York City. I'm Candace Hoffman, managing editor of Morning Commute. Dr. Radich will begin our discussion.
Michael, Jerry here. How are you doing?
Good. Fantastic to be joining you, Jerry.
Welcome to the podcast on the commute. You can hear I'm on a bus riding in from Sammamish to Seattle.
Excellent. Good coffee on board?
No. Just people, sadly. You know, I should probably get together and figure out how you are doing and how your family is, but rather than being civil, we'll just talk about CML. What else can we talk about?
What else do people talk about when they're commuting? They talk about leukemia.
Yeah, exactly. Doing and how your family is. So the topic of this podcast is going to be on third-line therapy.
Of CML.
And some of the challenges. And so let me do the picture of the usual patient that I see in consult for third therapy. Typically, someone has had run-ups of two different therapies, and they've been stopped either because they've had toxicity or because they haven't had a response. And usually their therapy has been on and off and stopped so frequently that you really can't tell whether they have actually responsive disease or not. And so you get a patient who, you run through a couple of TKIs and here you are, and you're talking about, do you have poor response and you have to go to a transplant or another drug, or, do we start a third line agent? I suspect you see similar types of patients in a referral center. What are you thinking about in third-line therapy when you get to someone who's kind of blown through two agents?
I think you nailed it when you said, you can't tell whether they're responding or they're or not, or we're going to be able to find a successful therapy. And maybe it's baseball related, but a third-line therapy is tough because we wonder, we're comfortable to change one, especially if we're trying to optimize response. We figure and especially when we move from a first generation to second generation, perhaps we get a little bit more nervous when moving from second generation to something else. And then when, if you're a third line, you're probably onto a third line, or, a third generation, or you're thinking about a third generation. So it's tricky. We're starting to get into that sticky area of side effects and risk benefit. And as you said, what about transplant? And that, kind of rears its ugly head. So it's difficult. I think that's why we're seeing these folks, Jerry. The community at large doesn't have clarity when it comes to third-line therapy, particularly, what is exactly the right agent. I think we got some new options to talk about, but and the transplant represents a completely different option. And I think the overarching philosophy is to try to skirt around that or to defer that. So I definitely I'm challenged with these same patients, and I hear you, and I think we should talk a little bit more about what the strategy should be.
So let's take two scenarios. Let's take a patient who you're pretty comfortable, maybe they've been even treated by you for the start of therapy, about what they've received and why they've changed. So let's say you've got a patient who is intolerant to imatinib, and they get switched to another second generation drug. You pick which one you want to talk about. And they're intolerant to that. So it seems like it's more ability to take the medicine than the disease being resistant. In that case, would you go to another second gen, since you've got a couple other varieties, right? If you started with dasatinib, you could go to nilotinib or bosutinib, or would you just say, I'm just going to go to the third generation and try my luck with phananta or now a seminib?
I think that's a great example. I think it's changed actually. So in my world, there's a good chance you might have maybe you started with imatinib and maybe you had tolerance issues with that. Then you're on to dasatinib because maybe we were trying to optimize response, or we saw something we didn't like, and you might have had a classic toxicity to dasatinib. You might have had pleural effusions or pericardial toxicity or something that might actually qualify as a treatment limiting or a therapy limiting toxicity where you're not going to re-challenge. But that kind of patient, you do have options. You could go a few different ways. In years past, bosutinib clearly was around and was a good option. Phananta was around and offered you so much hope for maybe conquering resistance if needed, but you're worried about new problems you might be triggering with tolerance issues, with cardiovascular toxicity, with other issues. So that was a tough decision. But I think now we have another option there with 2 TKI failures with the seminib. And I think those are all fair game. And I even say you could think about switch to nilotinib, or in the situation, although, moving back and forth between the second generation inhibitors, I think we all realize there may be some limitations there. You have to think about what's your sequence and what you're expecting for response, perhaps. For example, I'm a little leery sometimes if someone's not fully responsive to dasatinib, how well is nilotinib going to perform? I think there clearly are cases where it will. But I'm a little bit more inclined to think about something where there's some third line data.
Right. So that's the second scenario, right? So the first scenario is how comfortable are you, that we just talked about, was how comfortable are you to switch kind of laterally, second generation to another second generation, if it's just a toxicity issue. And I think most people would be comfortable doing that, right? But then the more difficult one is, and I think where phananta and seminib come in more clearly, is where you really have resistance, right? You've got someone who tolerates the drug fine, but it doesn't hit the milestones at all. And so they've either gone imatinib second generation, and then I think moving to another second generation doesn't make a lot of sense in that situation, unless they have a specific mutation that clearly calls for using another second generation drug, but that doesn't happen that often.
Agreed.
And then you got the situation of, do you do ponatinib and do you do seminib? And I think to me, a question of that also is, what do you do in the context of whether they have a mutation or not? Right. So let's say you've got a TKI failure for the imatinib. They don't have a mutation. They get a second line drug like dasatinib. They now have a mutation. So you have, somewhat, as they say, an intrinsic reason for resistance. Do you deal with those people different as to the choice of a drug like a seminib, which still is affecting TKI binding, versus ponatinib?
I certainly like the options we have in third line. I think ponatinib was fairly agnostic to mutations, was really active against T315I. I remember nice preclinical data that showed us that you really can't, you don't generate outgrowth of mutant clones very easily. I like asciminib with novel mechanism of action with allosteric inhibition and potentially not so much concern over what might be happening at the ATP binding pocket. I worry, we used to use this term, like a mutator phenotype. You have a patient who's got one mutation, and unless you're using pretty complex sequencing, you might not know exactly what you're looking at either. You might be looking at, one clone that's showing you an ABL kinase domain mutation, but that might have originated from another clone, and there may be other clones behind that. Over time, I think we all recognize it can get complicated. And I think it's interesting that the mutation, picking a drug based on mutation evidence and the frequency of mutations as a defining factor in choosing treatment isn't as important as we might have thought it was in the very beginning of this. It's clearly important, and I think we have still some areas to learn in that area, but I would tend to choose a third generation drug for the sake of overcoming that quote mutator phenotype sort of concern over other mechanisms of resistance. Well, I would also think about some of those select cases where a certain mutation might point you towards a certain second generation drug, but it's I think it's kind of fuzzy. I don't know what you think about the mutation. This is your thing. You're an expert in molecular diagnostics. Shed more light.
I think clearly there are cases where you see a mutation that should be sensitive to a drug and isn't. In some cases where you have a mutation that shouldn't be sensitive, it is. And part of that is because how those whole grid models are made is a completely artificial system, right? You take a cell line, you plug a BCR-ABL into it, you give the inhibitors to kind of get a baseline sensitivity, and then you one by one make mutations in that artificial construct. So as you're creating something that's not necessarily there by nature. So it's not surprised that sometimes we don't get that right? To me, if you believe the whole mutation stuff, in a case where you've got a mutation driving resistance, so you know that the resistance has something to do with tyrosine kinase activity, doing an allosteric inhibitor that gets at blocking that in a different way outside the binding domain makes a lot of sense. The ones I worry about more from a practice standpoint is these resistant cases that don't have a mutation. Because presumably, we don't know if to be true, but presumably they're still having their BCR-ABL inhibited. So they've made an end run about that pathway. And to me, that's an indication where something like ponatinib or even transplantation, because that people who have gone through 2 levels of treatment have a pretty high escape to accelerated phase of blast crisis, right? And so, I'm biased as a transplanter, but your chance of curing someone who's in chronic phase is 85%. Your chance of curing someone in an accelerated phase of blast crisis is, less than 40%. So those are the kind of patients I really worry about.
Well, the bus driver, let me ask you a question.
Sure.
I'm thinking based on what you just said, you were, so here's a question. Ponatinib versus seminib, non-ABL binding domain or non-ABL kinase mutation driven resistance. It sounds like you're worried about something else, even though we really haven't put our finger on one, key mechanism.
Yep.
Any difference there? You think one might be better than the other? Because I think I know the answer. I'm just curious.
If I just had to make a bet, right, and I'm not very good at betting, so I'll probably lose this bet. I would bet that something that has a very, very broad background like ponatinib is probably the one I would look for, just because it attacks so many kinases, right? And then you get into, of course, what dose and everything else. And that's probably also based on some of the data from some of the early ponatinib trials on really, really, really heavily treated patients and their ability to at least get some responses in those. But those are the type of patients that I worry about. And while I might not transplant them up front, I would certainly have everything lined up, donors and everything ready to go.
Yeah.
So here's another issue, and it doesn't really speak to a seminib because it's not in the FDA label for this, but resistance after your first line of therapy, right? Should you, unless you have a specific mutation that you really believe in, if you start with 1 second generation and that drug fails the patient, bearing in mind that people don't fail the drug fails them, does it make sense to move laterally to another tyrosine second generation, or should you just move to something beyond that? And or if you could change the FDA label as seminib.
Yeah, I do kind of worry about those patients that don't respond to primary therapy, especially if you want to be good primary, but potent second generation agent, something you'd expect to really have high rates of response. That's really worrisome to me. I feel like that patient may have some kind of built-in resistance, might have been there at the CML event. Maybe they, unfortunately had a little bit of evolution of their disease before they even started. When you carefully stage patients, you might see some other things like in those kinds of folks. High so-called risk, you might see clonal evolution, things, the old school type findings too. So I would feel that you might, as we were just speaking about, you might want something with a broader base. You might want something that really can nail the ABL kinase domain better, or maybe by an allosteric mechanism. I mean, I think that's the tipping point. We just don't know. When does CML when is the horse out of the barn? I think that we can really nail down ABL kinase activity even better than we ever could in the past, but it's not always the whole story. So I think hard to decide, but I would in general want to be moving to an asciminib ponatinib type option if someone was failing a second generation out of the gate.
And one last issue that since you're a guy that's really interested in toxicity and the like, where do comorbidities fit into all of this? If you had to rank them with the issues of response, mutations and the like in picking a drug, when do comorbidities trump that type of stuff? And when do you not care?
I think it's a gradation, when you have a clean slate and you have good high expectations early on, you really want to look at the patient's comorbidities and try to tailor the therapy and make sure you go high gain, low risk, hopefully. Acknowledging that no drug is perfect. I mean, some are obviously much safer than others, or at least more simple with regards to some of the toxicities they trigger. But as soon as you're moving into resistance, I think you have to back off a little bit, because I worry about people avoiding drug toxicities and missing the boat of being able to treat them with the right drug. I don't want to use phananta in this patient because it may cause a vascular event. If a patient's got a highly resistant disease, I mean, advanced phase CML or transplant's a whole lot more toxic than phananta. There was some nice data about in chronic phase CML, phananta served people for the crossing point when the toxicity for transplant versus toxicity for phananta was matched was about 8 years, I think, in an EBMT study, right? And then advanced phase, it was pretty, it kind of came pretty quickly, because that's just bad all around for those folks. We got to avoid that. So I think there's a gradation. I'm careful not to say contraindication to therapy either. I think things are relative. You don't want to say someone who has any toxicity in a certain organ system is completely out of bounds. I think you just have to manage it. I'm a big fan of great internal medicine and great CML care married together, but not always easy.
Oh, Mike, I got to jump. My bus stop's here. I got to get out and go to work.
All right.
So I'll catch you on the commute back. Have a good day. Stamp out disease, and we'll chat later on tonight.
All right, Jerry. Safe driving.
Bye.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/CML1. Look for all of our podcasts on your favorite podcast streaming services, or download our Morning Commute app for your iPhone. Thank you for joining us today.